Good morning, everyone. We will get started here shortly. We're just going to give another minute or so for everyone to join. Rachel, I will let you know when we have a quorum. We're just about there. If there are any committee members that are on the phone, looks like nobody's quite on the phone yet. But committee members, if you would go ahead and add your names to the chat, that way we can make sure that we get you captured on the meeting minutes. And again, we should be started here in another minute or so. Thank you. Okay, Rachel, by my count, we do have a quorum, so you can get started whenever you are ready. Thank you. Good morning, everyone.
Thanks, Sharon. Good morning, everyone. Welcome to our January MAC meeting. Happy to see you all. I'm working on getting my video started as usual. There we go. Okay. Well, while I'm working on that, I'll take a motion to approve our October 2025 minutes. Don't all jump at once.
Motion to approve.
Thank you. Anyone want to second that?
I'll second that.
Wonderful. We will vote by silence. So any nays to that? Wonderful. Okay. And then our second order of business is an exciting one. We officially have a new Medicaid director, as many of you know. So I'm going to hand it off to Julie to introduce herself.
Thanks, Rachel. Hi, everyone. I am the new Medicaid director. My name is Julie Ewing, and I'm going to apologize because I know a lot of you on this call have heard me give this spiel a few times about my background, but I think it's important to do here because there's some folks who haven't heard it. But I am an attorney by background. I spent 10 years at the Utah Attorney General's office where I represented various state agencies. But the state agency I always represented during my time there was the University of Utah Hospitals. I left the AG's office and actually came to Utah Medicaid, where I spent 6 years, exiting my career there as the Bureau Director for the Bureau of Managed Healthcare. Most recently, I have been at the University of Utah Health Plans, where I was the Compliance Director. While at the health plans, I was responsible for overseeing the Medicaid product lines that the University of Utah Health Plans operates, as well as overseeing compliance for all of their insurance products. So that included an ACA Obamacare plan, an ERISA plan. ERISA plans, we also did TPA work for various insurance carriers. And so there was quite a big book of business there that I was responsible for overseeing the compliance for. And then I also oversaw our fraud, waste, and abuse team. So monitoring for member and provider fraud, waste, and abuse. And I am now officially 1 month on the job as the Medicaid director. And I am just super excited to be here. To work with you all to help do what we can to serve make sure our members have the best possible services and have the best possible access to quality care. I would just add also on a personal note, I play hockey. I'm also a big Mammoth fan and love to read, love to hike, be outdoors. So if anybody wants to talk hockey as well as Medicaid, I'm here for you. So thanks, Rachel.
Awesome. Thank you, Julie. We also have some new members of the MAC. We have Riley Curtis, Emma Chacon, and Juanel Gomez Coulon. So if you all want to introduce yourselves, you can go in that order. You can just come off mute. I think we can manage it. We'd love to get a quick introduction. I know we know some of you, but
I can go first. Hi, I'm Riley Curtis. I'm the Senior Director of Community Collaboration for University of Utah Health. I have served on the MAC before when I was at Utah Health Policy Project doing Medicaid policy work for about 10 years. And I am the new hospitals representative on the MAC. So glad to be here.
And I'll jump in. I'm Emma Chacon, not new to this committee. I was with the Department of Human Services, the Department of Health, and then the Department of Health and Human Services for 45 years. Left the role as the interim Medicaid director, have failed at retirement twice, and I am now the Director of Medicaid Operations and Compliance for Health Choice Utah. I've been there for about 3 years, and yes, I have been on the MAC, representing departments, running the MAC, and now I am representing the managed care plans. So appreciate the opportunity to be back. Thanks.
All right. Well, I am new, so my name is Daniel Gomez. I am the commissioner representative from the Philippines. A bit about myself. Professionally, I am a compliance officer at Goldman Sachs. I sit on the Rare Disease Advisory Council, and I'm also a trustee for the Disability Law Center. I've been on Medicaid on these programs to Medicaid eligibility ever since I was a little kid on rare disease atrophy, and so appreciate the opportunity here.
Wonderful. Thank you all. Welcome and welcome back to many of you to the MAC. And on that note, we'll move to agenda item number 2, which is the back update from Dr. Iqbal.
Thank you so much, Rachel. Good morning, everybody. My name is Ronak Iqbal. I am the Medical Director for Medicaid in the Department of Health and Human Service, and I directly report to Julie Yu. We had our back meeting yesterday. It was a very nice quorum. We had 16 individuals attend the meeting. We, in addition, had 3 new members join us, for which we were very grateful. We went through the agenda item, and there were some questions that were brought forward that we have promised to bring back to the committee on our next meeting. Obviously, there was no surprise that one of the biggest concerns was the work requirement for individuals. And then the other concern was about the medical frailty. Very grateful to Brian and Michelle for their time in explaining to our members out in the community parts and portions of these concerns, but we still have to give them some definitive answers. In addition, we also welcomed Greg Tolan, as he is now going to be representing the division for the managed healthcare plans. And that is all the updates I have from the back. I'm happy to take any questions. Otherwise, we can move on to the next agenda. Thank you.
Hearing no questions for Dr. Iqbal, we can move on to agenda item number 3, which is the Notices Committee report from Gina.
Good morning. Thanks, Rachel. I'm Gina Bourne. I currently lead the Notice Work Group. In the past year, we have completed the standalone notices. The group has reviewed approximately 130 notices. During that time, the improvements that we have made, we have worked on notice clarity, clearly identifying time-sensitive actions and highlighting key sections, clearly including DWS business hours and contact information, including applicable resources as necessary, including applicable Medicaid and CHIP policy, as well as ensuring compliance with CMS guidance and tailoring notices only to include information that applies. Some of the accomplishments that we have accomplished over the years are making notices easy to understand and follow. So just using plain, simple language, visual layouts improvements such as headers, bold font, and other formatting elements. We've incorporated educational information into the notices pieces, just making notices accessible for individuals with disabilities, for non-English speakers, and make sure that the notices comply with all legal and regulatory compliances with CMS. And then I would like to thank those individuals that have contributed to the work group. It's, hearing their perspective and their feedback is important to ensuring that, we are making the necessary improvements to the notices, as well as, DWS and that internal work group. Their feedback has been crucial as well. And that's all I have. Thanks, Rachel.
Thank you, Gina. Are there any questions for Gina on the notices committee? Hearing none, I just want to remind people that this is a group that you can join. So if you're interested in joining the notices committee, let Gina or me or Sharon know and we'll connect you. I believe they're always looking for new voices. And then for agenda item number 4, we'll move back to Julie for an update on the governor's budget.
And Rachel, we actually didn't have a chance to coordinate this, but Nate Checketts is actually going to jump in and give the update on this
Awesome.
this item. So, and before Nate comes on, I did just want to mention, so Nate Checketts, he's held the title of the interim Medicaid director prior to my coming here after Jen left. And he is going to, I think most of you are aware, he's going to be moving on from the Department of Health and Human Services after the legislative session. He's agreed to stay on and assist with some things through the legislative session and some special projects. And so I just wanted to take a minute and acknowledge Nate. And I think he's done a lot of good work for the people of the state of Utah. And we really, he led the COVID response for the state. He's done so much. And so I just wanted to take a minute because I don't know that we'll see him at a MAC meeting again. So go ahead, Nate, jump on in.
Oh, thank you. Yeah, and thank you for that introduction. And then currently I'm in a senior advisor role with the Department of Health and Human Services and wearing several different hats, including our legislative affairs and working on the rural health program. So happy to be helping the department in a variety of roles here with my last couple months with the department. The governor's budget this year, probably not surprising to this group. It was a very lean year as we're coming into this process. And so the items that were recommended by the governor were also very lean. There were not many items directly related to the Medicaid program. Most of them were actually more along the lines of the maintenance part of work that we need to be doing in order to continue serving the individuals that we have on the program. So for example, related to services for people with disabilities, we have individuals that are aging out of the juvenile programs that we need to make sure we have funding for them as they go into the broader DSPD services. And also the individuals that are on those disability services, they over time need more services year over year. So that part was covered. That's in the budget that's identified as the mandated additional needs. That part was in the governor's budget and that was included. That was $12 million that was in for that function. There was also another mandated item related to Medicaid, related to our aging waiver. Over the years, as we've continued to experience cost increases in that program and not had additional funding for the program, we haven't been able to enroll as many individuals in that program. And due to some federal requirements that would say, given some other funding that we were provided, the need to maintain our programs and not reduce eligibility, we wanted to make sure that we were not reducing the number of people that were able to enroll in the aging waiver. And so another item in the governor's budget is about $1 million to make sure that we can continue to enroll all of the people that are indicated in that aging waiver that we already have in place. But to keep that enrollment up at the level that was expected for that waiver. There was also some funding in a related area related to the Medicaid program broadly, but securing Meals on Wheels and senior nutrition. That's been an ongoing issue that the state's been facing with some reductions in state funding and some reductions in federal funding. So the governor recommended $1.7 million for that function. And the last item that I wanted to mention was related to the opioid grant funds. So that the state has been receiving opioid settlement funds, and in previous years, the state has been using those funds directly for services. In a bill last year, they changed that process and identified that they only wanted to use the interest that we were earning off the fund overall for services. And so that provided a $1.6 million that's in the governor's budget for that interest to be used on certain opioid grant funds. So with that, that's where things landed in the governor's budget, and I'd be open for any questions.
I have a question, Nate, and you might not know the answer to this. I did see the item about the 1.6 million of opioid settlement funds being used as a grant program. Do you know what that grant structure would look like, if there's a cap on those grants, what kind of organizations would be eligible for them? I asked transparently, as you may know, 8 of the community health center organizations across the state get opioid settlement funds currently, and they run this year. And if that request were to be successful, we would want to know if they would even be eligible for those grants. I understand that you might not know any of that, and you might not have any to say.
No, that's a great follow-up question. We haven't released that information yet on where the governor's recommending those funds be used. I would say broadly, there are more programs being funded today when in that broader methodology that we had in previous years than what would be available to be funded in the 1.6 going forward as the legislatures shift that methodology. And so there is going to be, just in accommodating that, some paring down of programs and also funding amounts. But we'll be working with the governor's office to release a proposal that will say how that 1.6, what programs we would recommend. And then if that was adopted by the legislature, then we would go through a process of awarding out those based on the different groups within the 1.6. So it's a little bit of, we don't have that information out there yet, but we will let you know when that gets defined.
Thank you. I appreciate it.
And recognizing FQHCs are part of the work that's being done and have had some great increases using those funds on the number of individuals that are getting treatment through the FQHCs.
I have a question.
Yeah, go ahead.
You had said that there were services for disabled people that they were aging out of and that we're going to get extra funding. I was just wondering what services you mean.
Oh, yeah, thank you. Thanks for that question. So as part of our programs, if an individual is in our juvenile justice system or in our child welfare system, those funds are covered a certain way in our budget. And then as those individuals turn 18, then they move on to the adult part of our budget program. Excuse me, they move on to a different part of our budget. And so we need to make sure that the Division for Services for People with Disabilities has the funding to maintain coverage for those individuals. So for the individual, it's continuous. There's no change. But in our budgeting process, we need to make sure that the right organization has sufficient funds to cover them. And so that funding was included in the governor's budget, was to make sure, and I forget the number, but I believe it's usually between like 50 to 100 individuals each year that age up through the process. And it's a budgetary thing that we need to handle. Thankfully for those individuals, there's no change in service for them.
Oh, okay. Thank you.
Any other questions for Nate on the governor's budget? Okay, hearing none. Nate, thank you. If this is your last MAC meeting and with this state, thanks for all you've done. I know you've been to many of these and answered many questions, and many of those questions have come from me. So I appreciate it.
Happy to do so. And as many people on here have shown, maybe sometime I'll be back in someday in some other role. People don't stay far away, it seems.
Yeah, exactly. Thank you. with that, we'll move on to agenda item number 5, a Rural Health Transformation Fund update from Dr. Iqbal.
Thank you, Rachel. I would like to start by saying hearty congratulations to our Rural Health Transformation team. We had to submit our application in a very short time period. We were successfully able to do so. CMS announced the award. We received $195,743,000 for the Rural Health Transformation Program. We had budgeted initially for 200, and so now we are in the process of trying to re-budget our existing budget that we submitted to adjust for the slight difference in that dollar amount. Again, it's a very short window period. We have to resubmit this budget before the 30th of January. And so we are actively working to do this. In addition, prior to submitting the new budget, we have been informed that the legislature would also like to have insight as well as our leadership in the EDO division. Having said that, there have been a couple of changes in the Rural Health Transformation Program. Starting from the 1st of January, Brittany Okada, who was our project director, has now been moved into the EDO division and will be reporting to Nuna Phillips, as you all saw in the email that Tracy sent. It is very important that the EDO division has a close relationship given the importance of this grant, the funding of the money that's coming through. So please give all of your support to Nuna and Brittany in the process. Having said that, I do want to point out that we have posted a couple of positions that are available for the Rural Health Transformation Program in order to make that team really strong. If you know of anybody or are interested in applying for these positions, please do go ahead on our NeoGov website and apply for these positions. Lastly, I would like to also mention, as always, Nate has been great, and he has also agreed to represent us during this legislative session in regard to the Rural Health Transformation Program. As if Nate didn't have enough on his plate, he is a team player and has decided to take on even more. So I'm sure Brittany and Nuna are extremely grateful to Nate for this help. We are now in the process, the legislative session starts pretty soon, and we could use all the help that we are getting. Having said that, I'm open to any questions if there are. Otherwise, we are more than happy to go into the next agenda item.
Looks like we have a few questions. We can go to Matt first. It's the first one I saw.
Hey, Dr. Iqbal. Hi. I know let's go through the legislative session, but do you guys have kind of a timeline of when you might release those applications? And I assume it'll start in July for the award year?
At this time, I don't know the exact answer to that. I do know that Nuna is on this call as well, so she can fill in. But I do believe that it has to first go through the appropriation of the legislative session, which is the 30th of this month, and then we will be opening it up for our public entities to apply for various positions and grants. If Nuna has any other insight, please chime in.
Not hearing Nuna, I'll jump in. And so a couple different things that sort of milestones we have in the process with the legislature. As Dr. Iqbal mentioned, the early weeks of the session are our appropriations subcommittee. We have direction from the legislature that they do want to hear about the Rural Health Transformation Program at that point. We do have a milestone with a grant at that same time too. On January 30th, we have to submit our revised budget to reflect the $195.7 million. We don't know yet from the legislature how much they're going to authorize us to do at that point in those appropriation subcommittees. We don't know if they're going to ask us to also present or for this item to be considered by executive appropriations during the legislative process. And so given some of that uncertainty, we we are targeting loosely that by the end of the session, we will have our legislative direction. So that would be by early March that we would have that. And then we would hope to go as soon as possible to move into the competitive award process from that point. The grant year is really awkward related to some of these dates. The end of the first grant year is October 30th. And then we have until September 30th of the following year, kind of get my dates lined up here to spend those funds. And so this has been an interesting grant process with the federal government. It's gone very fast through certain components and not allowed some of the normal timelines to work through. So I know that's a lot of uncertainty, but our hope would be that, again, depending on what discretion the legislature gives us when they appropriate those funds, but our hope would be that we would start going through that competitive process in the March, April time period.
Thanks, Nate.
Yeah.
Catherine.
Good morning. Thanks, everyone. Great to be here. So the legislative appropriation process, that seems a little different than other states. Is that unique to Utah in terms of the rural health transformation grants? That there will have to be an appropriation. Will that change your application, you think? I know it's all speculation at this point.
Nate, you want to take that question as well?
Sure. I can't speak to what other states are doing related to that process, so I don't know how unique we are. Utah likes to be unique, so even if that is unique, then it may be even a badge of honor that we're doing it differently. In some ways, it's not that different than what we had originally envisioned. The state already has a law in place that says before we can apply for these funds, we need their authorization to apply for them, which we did get last year. They have pointed out that the funds still need to be appropriated to us. That could be a mechanical process, a technical process that just says 195 million. It's now in the DHHS budget. It could be a directive process where they could say in other parts of our appropriations, they have this request for appropriation process where they say, give $500,000 to, and I always pour San Juan, but I always pick San Juan, give $500,000 to San Juan County. And if that's the direction we get, then we would give $500,000 to San Juan County. To one part of your other question about would that require a change in the application or would that go against the application? Potentially it could. We're hoping to work with the legislature to help them work through the process that we do have a notice of funding award, and that gives us certain initiatives that have been approved, and there's federal guidelines on the grant overall, so that ideally any direction they give us would fit within what has been approved and what is the grant allows, so that there's no need to go back to CMS and try to revise any of this at a later date. We're not sure CMS would even be open to that in sort of this time frame. And again, we're back to these really tight time frames that maybe a future year could be impacted by some of those adjustments. But in the current year, we will have already submitted our draft budget, our revised budget by January 30th.
Yeah, it's a really tight timeline. One last question. Do you think you're going to hire, thank you so much for that, Nate. Do you think that you're going to hire a third party to do the applications, or are you going to process that internally? Just please.
So my understanding so far is that we are doing all the application processes ourselves. I have not heard, and please correct me, Nate, if you've heard differently. So far, we've been working on it ourselves. Our team, our Rural Health Transformation team, has been working diligently to make all the changes and the budgetary changes, of course, with the oversight of the EDO.
Thank you.
You're welcome.
And Melissa.
Greetings. Thank you, Rachel. Dr. Iqbal, I work closely with the tribal governments across the state of Utah, and I understand that HHS and CMS at the federal level acknowledged that they had not included the tribes in the initial application process for funding as tribal governmental entities. And their guidance indicated that they are requesting states to work directly with tribes in a set aside kind of a formula. And I'm wondering how you all are attempting to do that or initiating that with the tribes throughout the state of Utah.
Thank you, Melissa, for that question. Yes, that question has come up on multiple occasions. So I know that in the past, we have always had a tribal cutout when we've received federal grant. This grant, this is not a grant, it's a cooperative agreement. So it's a little bit different. Some states, I'm aware, have made a specific cutout for their tribal areas. Utah has not done that. What we are trying to do is we are trying to sit down with our tribal entities and have a conversation with them and try to competitively apply for applications for the grants that are available. We actually, in the coming week, have one meeting with one of the tribal agencies. We've had a good relationship with them, and I know that they would have liked to have a carve out. Unfortunately, that was not something that we put in our application. So as we stand at this moment, the tribal entities don't have a flat carve out. They are eligible to apply for any of the competitive portions of the grant, just like any other entity that is working in rural Utah.
Thank you, Dr. Iqbal. So to summarize that, your application that you'll be resubmitting on the 30th will not include a carve out or a set aside for the tribal governments, and that goes to CMS for approval. Is that right? Is that the next step?
That is correct.
Thank you.
You're welcome.
I just want to make a comment on that. If the legislature gets incredibly involved in this process of awarding funds, I worry about not only the tribes, but specifically the tribes, but smaller entities being left out because they don't have the lobbying power or even the information to know how to go through the RFA process if they decide to be more menial about it. It sounds like the decision's been made about the carve out for tribes, but I would like to suggest if that can be considered at all. I think if this gets into kind of a more RFA-like process, I think it could ensure that the tribes aren't completely locked out. I can speak for the tribal FQHCs and some of the larger organizations. They might have, the manpower and the know-how. Obviously, I'm around for some of them, but the smaller entities, I worry that they would be locked out. And that's also true of smaller healthcare entities as well, smaller providers. But I just wanted to say that.
So to answer that question, Rachel, your concern is very valid. I would like to inform everybody who is in touch with either a small entity or a tribal agency that RAW has actually, as part of their membership, is now helping people apply and give them the knowledge of how to apply for these RFPs. So if you're a smaller entity and you don't know how to walk through the process, I would highly encourage you to please apply to RAW membership, which is a very nominally small fee, but they are incorporating individuals for the entire purpose of helping smaller entities to apply for the grant properly. So that's the first thing. The second thing I do want to assure everybody is that this money is for rural Utah. So it cannot be spent anywhere but in rural Utah. So all entities that are present in rural Utah are eligible as long as they fall into those buckets where our application has been applied for. And you can find all the information about our application, the entire application that we've submitted so far, on our website, which is the Rural Health Transformation website. And I will shortly put the link of that in our chat as well for anybody who could use it.
Thank you. We'll definitely try and get the word out. I think it's less about even, I won't get into it. I think you know what I'm talking about.
Yeah, it's complicated.
Yeah, and I know that it's not necessarily your decision on how these awards or maybe RFAs get done. So
That is
anyway, any other questions for Dr. Iqbal on the Rural Health Transformation Fund?
I'm still seeing Melissa's hand up. I wonder if you had another. Oh, it went down.
If not, thank you guys so much. I know this was fast, to say the least, and it was a lot of work, and it's not done, and it won't be done for quite a while. So I know how much work this has been for all of you. So I do appreciate it. This is never going to be perfect, obviously, for a lot of different reasons, but we appreciate it, and continue to let us know how we can be helpful as this process moves quickly.
Thank you for that.
Yeah. And then with that, we can move to agenda item number 6. That's a HR1 update from Michelle.
Yeah. Hi, Rachel. Oh, go ahead, Julie. I was just gonna toss
You're
it
gonna
over
say
to
what I'm gonna
Tom.
say.
Yeah, go ahead.
Oh, I was just gonna say, Rachel, as we discussed this internally, we felt like the TAM conversation might make sense to have first, and then jump into the HR1.
Fine with me.
Okay.
Then instead, we're gonna move into a TAM update, Targeted Adult Medicaid discussion with Brian.
And I'm actually gonna kick off this conversation. So TAM, so Targeted Adult Medicaid. We wanted to come and talk to you all about this program and kind of what the future of this program looks like. So as I launch into this, there's one thing I just want to point out. The TAM conversation also, it dovetails quite a bit into HR1. And so just wanted to mention that Michelle is going to talk about the HR1 stuff. HR1 is how we're going to be referring to the One Big Beautiful Bill Act, because that is a mouthful to say. So we're just going to shorten it down to the HR1 as we talk about it, but that's what we're referring to. And so TAM, Targeted Adult Medicaid, is a Medicaid expansion program that was aimed to reduce the uninsurance rate and help particularly a really niche subset of the population get access to care. It was the first expansion that the state did. The state subsequently expanded Medicaid more broadly through the ballot initiative, but TAM was the first expansion population that we actually brought on. And the program was designed for adults without dependent children, earning up to 5% of the federal poverty level, who were chronically homeless, justice involved, and needing treatment, and needing just a broader category of needing substance use and mental health treatment. And it was enacted by HB 437 in 2016. And the 1115 waiver request, we got that approved on November 1st of 2017. So that waiver that we have approved, it is set to expire in June of 2027. And I would also note that the One Big HR1, those requirements of work requirements and the eligibility changes, those requirements go into effect on January 1st of 2027. So we have a 6-month window where we have a waiver in place with the federal government for TAM, where we have 12 months of continuous eligibility for TAM members. And maybe let me just back up. The two things made the TAM program unique. One was it had 12 months of continuous eligibility for individuals. So the individuals who were maybe justice involved, who, re-enter the community, get jobs, they wouldn't lose their Medicaid eligibility within that 12 months. And it was really a program intended to help folks get on their feet like that. And then the other thing that TAM had that made it a little unique was dental benefits. Now we actually have the expansion population does receive dental benefits. So TAM is no longer unique for that with the expansion population. So we have the waiver expiring, and if we were going to renew the waiver, we would need to submit the waiver by a year in advance. So June of this year is when we would need to submit this waiver. And we're already getting information from CMS that they will not renew the waiver with the 12 months continuous eligibility as a result of the changes in HR1. And so as we have talked through what to do with this population, the proposal we're bringing for feedback and for your information is that we are looking to have the TAM population just move in to the service delivery model that the expansion population currently has. Because if the TAM program can't exist as a standalone population, these individuals will still be eligible for Medicaid under the expansion, the general expansion. And so our proposal is to move them into that service delivery model, which means that depending on where they live in the state, they will be in an integrated plan. And that would probably be most of the population would move into an integrated plan. And then other parts of the state, they may be moved into an ACO or with a PMHP. And there are some populations that also may end up having some services delivered fee for service. So that's the proposal we are bringing. I would also just note that there is a state statute out there that says that the TAM population can be moved into managed care. But there are certain requirements that the managed care plan has to meet, that has to be in the contract to be eligible to deliver services to these members. And we have to make sure that the contract includes requirements that the plans be in compliance with federal Medicaid managed care requirements, that they have to timely and accurately process prior authorizations and claims, that they adequately reimburse providers to maintain adequacy of access to care. They have to provide care management services sufficient to meet the needs of the Medicaid eligible individuals. And then they must also timely resolve any disputes between a provider or an enrollee with a managed care plan. So I'm going to stop there. I'm sure there's lots of questions. Yeah, please jump in and give me your questions.
Yeah, hi, this is Daryl. Just to clarify, so the proposal that you are suggesting essentially is identical to adult expansion Medicaid.
Correct.
There's no, okay.
Julie, can you give clarification on how this change might affect dental benefits?
So the dental benefits are all delivered through the School of Dentistry for TAM, as well as for adult expansion. So individuals shouldn't see a change in their dental benefit delivery.
Great, thank you.
So, two things. From what I know, there is a somewhat streamlined process for applications for TAM. I would ask, I mean, this is probably a bigger ask, and this is ahead of, and this is more work ahead of like HR1 altogether, is that streamlined process, if possible, be adopted for the entire expansion population. I think that there are some things that are faster about that application. There are some things that are slower too. But I don't want to point to the specifics because I'm not an enrollment person, but I know that we have folks that can point out what areas are easier for TAM applications. So that's one thing that I think would be helpful if it could be applied to the entire expansion population, if at all possible, knowing how long the application process takes right now for Medicaid. Secondly, and this is specific to rural areas, and I don't want to call anyone out or get like too granular about this, but we have some concerns about availability, or I shouldn't say availability, but the ability for Medicaid expansion folks to be able to get into inpatient care in some rural areas for behavioral health. It's been an issue that's popped up at least probably as long as I've been in this role. So that's 6 years now. And I'm happy to have a longer conversation about this. We've had this conversation with Medicaid specific to tribal beneficiaries, but it does happen. We see it in quite a few rural areas that Medicaid expansion members will be referred to inpatient services at their local mental health authority, and then they are reevaluated there and said that they do not need those inpatient services, and then they cannot get into inpatient. So that's something that I have great concern about, and I do not believe it's a problem with the TAM population now. And I know that TAM generally is more in the Wasatch Front areas, but we do have justice involved individuals on the TAM program in rural areas. So those are my two concerns kind of off the bat. I guess one's an ask, one request, the other's a concern.
No, thank you for that. We'll take that back and have more conversations about that.
Steph.
Hi, thanks, Julie. I guess a couple questions that I have that I just want to ask in this meeting is, I'd like to understand more about y'all's conversations with CMS as it pertains to the fact that HR 1 did not explicitly say that you can't have 6-month continuous eligibility. And so I'm just curious about whether or not that was explicitly said to you guys in like a phone call or a meeting, or like, I realized there was like the Dear Colleague letter, but it doesn't explicitly prevent the state from pursuing a 6-month continuous eligibility portion, like changing the waiver to that. So I want to understand that. And then this, I guess my second question, which I realize might sound, might be hard for some people to hear, is just, you're making it look like Medicaid expansion. Why was there a conversation about having Medicaid expansion actually look like TAM entirely? Meaning part of what I hear from people and what I experience when I'm helping people is that TAM is like, it's a much more open network. Like they are not restricted to a health plan. And so was there a conversation about just going, making some changes to where adult expansion no longer was a health plan centered, Medicaid benefit program, and it was, we just had it look more like TAM, just so that there would be some, I'm just curious, like I hear that we're going in that direction. Was there also a conversation about the trade-offs, pros and cons of going in the other direction? I guess those are my two questions.
So I'll take the second question, and then I'll look to Michelle or Brian to speak to the conversations that were had with CMS prior to my coming to the Department of Health. And so I would say, no, we didn't think about moving expansion into the ACO PMHP system. That wasn't just expansion generally. We did talk about moving TAM into that system, and realized that there's some complications with EREP and how the DWS applications process was probably going to work for TAM, that we didn't think that we could shift folks into the ACO and PMHP system, but we did not have the broader conversation of looking at the expansion population generally in its service delivery model. We were just looking at the TAM population.
Or sorry, maybe I didn't say my question right. I guess what I'm saying is, like, right now adult expansion are with the ACOs. So I guess I'm saying like TAM isn't, it's an open network. And so I guess I'm just asking, did you guys talk about adult expansion moving into a fee-for-service model where it would just be, where we would no longer privatize those particular beneficiaries into the health plans? That's what I'm trying to get at.
Yeah, and so no, we didn't discuss that either. We were just looking at what to do with TAM and not the broader expansion population, and switching up the service delivery model that we have, because that would be a big a big move. And then Michelle, do you mind taking the first question?
I can jump into the CMS question, and thank you, Stephanie, for that question. So I understand you're well aware of that Dear Colleague letter. I'll point to that, and I might just explain the Dear Colleague letter for the broader group. I know you, Stephanie, are well aware of it, but just in case anybody on the call is not aware of it. But this is, I'll post it in the chat as well. there are some pieces in the letter that I would agree with you that are not as prescriptive in CMS language. But then there are some other verbiage within that letter that is quite that gives insight into CMS position, that they talk about CMS will work with states on how to end the authorities for any state's continuous eligibility provisions that do exist, working on a phase-out plan, explaining to states that this authority for continuous eligibility is time-limited. Those are positions from CMS that we read in the letter and then have been reinforced in oral conversations that we've had with CMS after the fact. One important thing that I will note is that it's not about the number of months. You may see in the letter that it really doesn't say that it's a matter of the 12 months being the operative duration. It's really about continuous eligibility going beyond statutory authority is what they say. So we don't view that like, well, nothing in this letter leads us to believe that 12 months is not okay, but 6 months might be okay. We are viewing this, and CMS's positions that they've reinforced orally after the fact is that anything beyond statutory authority or non-waiver authority is not going to be approved or renewed by CMS. So I'll quickly say, like, there are other populations that continue to have continuous eligibility. Children, for example, that's written into law. And so that will remain the law of the land unless Congress were to act. Another option for the postpartum continuous eligibility remains to be an option to states, and we continue to take up that option. CMS has just taken the position that, like, where it goes beyond those federal provisions, they are no longer going to approve or renew that. And so that, and we've seen other states take action on this. Colorado was working towards implementing a new 12-month continuous eligibility for adult members involved in the justice system. They were preparing to go live with it 2026 actually, and did an abrupt stop based on this letter as well. So other states are acting as well, similar to us, with this understanding that continuous eligibility would not be an option by CMS going forward.
I guess like they restricted it to 6 months. And I think because continuous eligibility had always been at least 12 months, are we sure that it's just like, is there a way where maybe we could just talk about having 6 months of retrospective, or prospective, I guess is the word, like prospective income determination, where it's like, here's what this person is like going to be their allocated income eligibility for the next 6 months, just based off of like the last 3 to 6 months of wage and paychecks. Like, is there ways where it's like, maybe the continuous eligibility is like triggering now to CMS. So like, is there ways where we can work around that so that, ultimately what we need is that recertification time periods are the only month that a beneficiary outside of their own, calling up and saying, hey, I got another health plan, I can drop my Medicaid, like outside of any initiation on the beneficiaries, we don't need to have people getting all of these change report notices and monthly just communication from DWS that is leading to them disenrolling procedurally. And I think that's the big concern. And so like, if there's any way that we can work around that, that is the goal. And it feels like I would like to see more creativity, frankly, respectfully, because we can't just like, I don't like this idea that we're just going to go ahead and just get rid of this program that has been such a critical part of helping so many people access services in the best way that meets their needs in that moment versus, and it works for providers and it works for so many, people, and then just push them into a population that they're really not that much alike in terms of their service needs. And so then to just like, I don't think the health, and like just all the capacity that would need to be on the case management side on the health plans, like I don't have enough confidence in that from my perspective of helping beneficiaries. And so it just feels like that's a lot to just be doing. And I would really like to see any efforts to like, maybe it's not continuous eligibility, but like what else can we do to try to like mitigate the damage of this is what I would really like to see more of. And I know I'm not on the MAC anymore and I just talked a lot, but so thank you all. But this is really important. So I just needed to bring some of these issues up.
Thank you, Stephanie. And I'll add briefly before we go to additional questions. So I do respect that, and we will take that feedback for perhaps other creative. As I read it, it is a prohibition on acting, or continuous eligibility is a prohibition on acting on change in circumstances. And so less about like how we calculate at the initial application, but what we do on acting on changes in circumstances that happen during the certification period. And CMS does reference that language in that Dear Colleague letter about acting on changes in circumstances. So I would still view it as something that CMS will require states to act on changes in circumstances that happen during the certification period. But
then Brian, wouldn't every state look the same in terms of procedural disenrollment? Like, wouldn't you see, I guess, like, we wouldn't have so many gaps, right? Like I would have friends in other states. I talked to Medicaid members in other states. They would also be getting monthly notices. Like they don't, like we do have different approaches here. And I guess that's what I'm trying to get at. You know what I mean? So I hear you. And that's a good point of like, it is defined as like not acting on changes, but it seems like they're acting on changes regardless of whether that person is eligible or not. So people are being procedurally disenrolled while they're still eligible because they made $10 more or they had some other change where it's just like, I don't know why they're being pinged for this, but it's because of the electronic data sources constantly harassing, like leading to what I think is like a level of harassment for some people. And so I guess that's what I'm getting at is like, that is not happening in every state, right? Because if it was, there would be like equal procedural disenrollment, equal, like you see a lot more equality in like the metrics, and we don't see that. And I guess that's what I'm that's what I'm just trying to get at a little bit.
okay. Yeah, I respect that. Perhaps that is something that we can explore more. I do respect you had some good conversations with us part of this meeting about other states, and I think there may be some additional things that we can engage on about like what is different with those other states. I think that may be a helpful conversation to have.
Yeah, like, and Andrew, we'll go to you right after this, but I want to reiterate that I was kind of talking about some of the notices that are set, and specifically the ones that wouldn't like a change of address within the state, right? Like that generates a change report, and if someone doesn't fill that out, they get kicked off the program sometimes. And so I brought that up in a work group specifically with conservative states, and they looked at me like I was crazy. Like, and these are including like the states that have expanded. Like they looked at me like I was crazy. Like so there has to be a way that we can do, and this is something I think that like I'd like to see going into HR1, and maybe that's part of the conversation next with Michelle, but like kind of us reevaluating how we do enrollment and eligibility in the state, because we know there's going to be a lot more barriers put up to enrollment. So if we can rectify some of the ones that we know that already exist that we can, I think that would be appreciated. And then Andrew.
Rachel, if folks have more on this specific subtopic, I have a different a TAM related question, but a different question. So if we're through with this piece, that's fine. But if folks have more, I don't want to prematurely switch subtopics.
Daryl, were you going to be on this topic as well?
I think I was going to be talking about ACO oversight.
Okay, then Andrew, I think you might be good.
Okay. Julie and/or Brian, I apologize if I missed it, if you already talked about it when you were talking about the making TAM look more like ACO coverage. Does that or not ACO expansion coverage? Does that also include the moving it to expansion income limits or not?
Julie, would you like to
ahead,
do
Brian.
that, or I can? Yeah. So the income limit would for adult expansion at 133% of the FPL, and that 5% disregard would still be the upper income limit for expansion. No changes proposed with that. So
would the folks that would somehow roll from TAM into expansion, the TAM eligible folks that would then be rolled into something that looks like expansion, would they maintain the 5% FPL, or would they be allowed the 138?
So maybe if I can rephrase it a little bit. So at the point, what we're proposing is that when the TAM authority ends, such an individual that would be at that 0 to 5% FPL, when they apply, assuming they meet all other requirements, they would just become eligible for adult expansion.
Okay.
So does that help answer? It's
does.
less about like a adult expansion like product. We're just saying that individual post TAM demonstration would just become eligible for adult expansion.
That was my confusion point, and that was the clarification I needed. Thanks.
Yeah, thank you for the question.
Am I next?
Yes, sorry.
So just regarding, Julie mentioned there are certain requirements on the ACOs if they should take this population on or this contract with the state that were pretty like generalized. I'm kind of wondering if the state has the ability to require things of the ACO that are specific to this population that we're trying to serve, like requiring that substance use treatment benefits be equalized both in and out of network.
So we can require things in our contract that are outside of the things I mentioned in the statute. And those were obviously very broad categories in the statute. So we'll need to look at, what that really means. And then I would add on top of that, there are just in the agreements with the ACOs generally, there are a ton of requirements relative to access and quality and other things that aren't just limited to those items that I mentioned. And so we can, if there are particular concerns about network adequacy and individuals aren't able to access substance use care that they need, we can look at what we need to do to adjust and audit for network adequacy and individual member access. So does that make sense?
Yeah, that does make sense. I think just one of the features that I think really helped folks was people that needed substance use treatment was sort of having a broad, list of choices, basically. Yeah. Thanks.
Evan, is that your hand? Sorry, my computer's.
Yeah, I was going to just comment that I think in this discussion, and I'm not advocating anything one way or the other, but just providing information, you know, we kind of talk about the TAM population as though they are forever TAM and they never change. But I will assure you that either because of changes in their circumstances, especially after the first year, even now, or because of, you know, eligibility, sometimes eligibility related mistakes, this population goes back and forth. They go back and forth between TAM and adult expansion. I think there's some assumption that the integrated plans right now are not providing services to these folks. We do every day because once they hit that 12 months continuous eligibility in their first review, and many of them are required, you know, either because of court order to, you know, obtain employment, they're suddenly adult expansion and they get enrolled in an ACO. And that doesn't mean that their substance use disorder issues have gone away or their mental health issues have gone away. And so we're providing care management and services to this population as we speak. And so can we all do better? Yes, we always can do better, but this population does go back and forth. Or for instance, a woman who is TAM and she becomes pregnant, she doesn't stay fee for service. She ends up coming to a managed care plan and then may stay in a managed care plan or may go back, you know, to fee for service depending upon circumstances. So it's not a one size fits all. This population is floating back and forth between delivery systems all the time.
Daryl, do you have another question or is your hand just still up?
Oh, sorry, my hand's just still up.
That's okay. Anyone else have any comments and questions? And then as people think if they have any, Julie and Brian, I presume are there gonna be other opportunities? I know because some people are just getting this information for the first time and there's obviously probably some people not here right now either. What are the other best opportunities to provide feedback and comment on this change?
Oh, go ahead, Brian.
Yeah, happy to. So since we're getting this feedback through MAC, and Sharon helps us tremendously in the running of MAC, we talked about getting such feedback through Sharon. And Sharon also helpfully back in the day when we had those House Bill 413 work groups as well, managed that. So she, this is certainly up her alley to help compile feedback that we receive related to this. So maybe Sharon, if you just would put your email address in the chat as a reminder. There you go. Thank you.
Perfect. Any other comments, questions right now? If not, yes, please see Sharon's chat for her email if you don't already have it, although I suspect many of you do. All right. Hearing no other comments or questions for the time being, I believe now we can move on to the HR1 discussion with Michelle. Thank you, Brian and Julie.
All right. Thanks, Rachel. Hi, everyone. I'm going to go ahead and present my screen. So let's see. All right. Hopefully you all can see that okay. Yes. Okay, perfect. I'll go ahead and jump right in. So I'm happy to go through kind of our HR1 project status with you all today. I have a few items that we'll be covering today just to kind of give you guys an overview of what we've been up to in terms of our research and planning with the project. I just ask just for helpful because I won't be able to see the screen. If you have questions, maybe we save to the end of the slideshow. I hate to ask that, but it just makes it a little easier to get through the slideshow, and then I'm happy to take questions. So without further ado, we'll go ahead and jump right in. Hopefully this right here looks familiar to you all. I know back in August, I believe, or September, we reviewed this just high-level timeline of all the different Medicaid provisions that are in HR 1 that will impact us and their different effective dates. Just keep in mind for today, I'm going to be focused strictly on the eligibility provisions for this update. In future meetings, we will be bringing status updates and what's happening with the other provisions, but I will be focused just on eligibility today. So I kind of want to start off and reiterate what our vision is in implementing all of these different eligibility provisions. It's pretty simple. We want to ensure that all individuals who are eligible for Medicaid can find a path to get onto Medicaid and to maintain their coverage with little to no barriers. We've learned a lot of lessons through unwinding, and we're applying those here as well. So hopefully you can see that as I go through this. I'll be covering 3 key areas of our project. So first of all, policy analysis and planning, data integration and system readiness, and stakeholder engagement and communication. So we'll jump to the next slide. So policy analysis and planning here, I just want to mention, you know, in order to implement this bill, Office of Eligibility Policy at DHHS as well as DWS have formed a dedicated project team. Although we're still waiting for their CMS guidance to fully round out our research, we have already begun pivoting into our system and policy design to ensure everything is ready when these deadlines come into play. So what does that look like? What have we been up to? So a couple of highlights here, progress up to date. We've completed our full comprehensive analysis of HR 1, gone through and identified impacts in all of the key areas for operations and policy. One thing I would like to note here that I believe is super important for everyone to understand, and not sure how much of you have read each of the provisions and in the bill, but one piece specific in the community engagement provision is that none of those requirements are waiverable. So everything that is in the bill is not waiverable. So I know I've received some different questions or, you know, inquiries about, you know, could we do this different or could we add this? That's very clear in the bill. The only thing that is waiverable is that we can go, we can implement earlier as a state. That is the only thing that we could do that's different from the bill. So I did want to point that out. We have completed our identifying of all of the different state options in the bill and recommendations to leadership. We do have final decisions on those. So I'll be working closely with Colby to be putting together a summary of what that looks like. And we'll be posting that to our webpage, which is the medicaid.utah.gov/ABA. And I have a link to that here as well that I can share. But we will also bring that here to one of future MACs, just so you guys can all have that. I think it's really important for you guys to have that transparency for us to show, for example, with community engagement, one of the options at application is as a state, you can choose a look back period of 1, 2, or 3 months of compliance. We have chosen as a state 1 month. So that's what our state will do. So just examples like that, I think it's important for you all to know and understand. So we'll put that out there. We've also completed a gap analysis of the Medicaid and SNAP requirements. SNAP has also had some changes with our work requirements. And in our previous 1115 waiver amendment, you know, a lot of that was structured around aligning with the SNAP program. With HR 1, it really kind of breaks that apart, and we don't have a whole lot of alignment, but we do have some things that do align. And there is a very specific provision in the bill on a SNAP exemption that you're only exempt from the community engagement requirement if you are compliant with SNAP, but not exempt. So it's kind of a tricky one. So in this gap analysis, we're looking where we have alike exemptions, and we can grab, whatever paperwork has been provided for that SNAP exemption and use it for Medicaid. Again, that idea, I think, Rachel, you said this is really our key thing we're looking at. How do we implement this with the least amount of to no barriers, right? So that's one thing that we're actively doing right now. We're also working on conversion planning. What does that mean? There's some things that we have to do when this goes live in terms of identifying folks who will be impacted when they're coming up for reviews. There's an outreach campaign that has to occur no later than September for individuals who were impacted. So we're busy putting together that plan to make sure that we're extremely thoughtful and mindful about what we do with converting people to this new requirement and making sure that everyone is fully aware and is ready for these new requirements. Next steps, what we're doing right now is we're actively drafting our policy, procedures, system requirements, trainings, communication materials that include our member notices. Those member notices will go through our normal pathway, like Gina just reported out earlier on the progress, really great progress with the notice work group. We'll be bringing these notices to that work group for your feedback. We do need that. So that will be a really important step in this process. One thing I would like to know, we have received some CMS guidance. We're still waiting on a lot more guidance. Our project team has actively been involved in national calls with NAMD and CMS, bi-weekly calls where we're getting some really good answers to a lot of outstanding questions that we have, but we still have some outstanding questions. One thing I would like to pause here and just note and maybe pivot over, allow Brian, you to maybe talk about this. One of the things that we got in the preliminary guidance was specifically around medically frail exemptions and a screening tool and what that looks like. So I kind of want to talk about that just briefly here, and because I know that's on a lot of your minds with medically frail. So I don't know, Brian, if you could maybe just briefly talk about kind of what we know right now about that exemption and some of that preliminary guidance that CMS has given us.
Yeah, I'm happy to. Thanks, Michelle. So yeah, I think that's one of the biggest pieces of forthcoming CMS guidance that we're looking to. What they've said preliminarily is that they are going to be very prescriptive for states, and states are not going to have their own leeway to define it for themselves. So we do expect a lot of definition at the national level that is required for all states to follow. Many here may already know the medically frail definition that's in CFR that pre-existed this law. And in fact, Utah had some experience with the medically frail definition in a small respect. When we had the non-traditional benefit plan, we had an avenue so that people could be recognized as medically frail and get a greater benefit package, the traditional benefit package. When we got rid of the non-traditional benefit package, that became an obsolete Utah policy, but other states have some more definition on that medically frail definition and the diagnoses that fall under it. So CMS, excuse me, frog in my throat, is working with some national leaders. So NAMD is our National Association of Medicaid Directors. They have convened the medical directors for each state. So our own Dr. Iqbal has been in conversations with other medical directors across the states and providing some input as well as just early recognition of some constraints. But what we're seeing and hearing is that CMS will expect states to validate medical frailty, whenever the specific definitions come down, validate it through claims and encounter data and durable medical equipment use, as well as pharmacy drug use that may be indications of medical frailty. And then for individuals who do not yet have claims or encounter experience, like a new applicant, that the state could provide a screening tool. It is unclear exactly what that screening tool will look like, but it would allow, we think it would allow an individual to make the assertion without like a doctor's note, but just the assertion through the Medicaid application that they do meet the criteria, and then CMS would expect the state to validate that through claims and encounters within 6 months after enrollment. So the screening tool would allow them to get on the program with that assertion that they do meet the medically frail requirements, but then we would follow it up with verification of their claims and encounter experience. So that is what we're expecting. We're starting to compare to other states as well, set their longstanding medically frail processes and diagnoses, and just to make sure that we're trying to follow some best practices. But we do view our goal is to make it as seamless and authorizing as many people that do meet the criteria without their knowledge, that we can just use claims data from our system to feed to EREP without participation from the member that recognizes that medically frail exception.
Yeah, great. Thanks, Brian, for giving that explanation. And I'm sure some of you might have some questions on that once we get to the end. So definitely save time for that, but thanks for adding that. And as you can see, you know, we're being extremely thoughtful in how to, you know, increase our ability to access additional data, which is a good segue into this next slide. So the next key area is around data integration and system readiness, and some of the work that we've been up to here. Data. Utah's higher education system, USHE, we're actively working with them, getting an MOU in place so that we can make that connection. One of the requirements under community engagement is if someone is enrolled half-time in education, that qualifies them for compliance. So again, in the spirit, right, of not having to request information from that applicant and member, we want to have this data source. So we're working to get that in place. The next one here, what Brian just mentioned around medically frail, you know, we're setting up that connection with our data warehouse on DHHS side and to have that interface with our eligibility system, EREP, to share if someone is medically frail. We're also making a connection to the CCJJ portal, which is kind of a central hub for all incarceration information for incarcerated individuals. That's another exemption in community engagement. If someone is incarcerated, they're exempt from these requirements, but they're also exempt for 3 months after they've been incarcerated. So to have that data will help us out tremendously with these folks. We're also working to make a connection to the NCOA, which is the National Change of Address Database, which is basically the U.S. Postal Service. That should go into place March this year. So we're really excited to have that information. Another piece I would point out, just with our with this slide specifically, is we are actively working on putting together a dashboard for community engagement navigation in MyCase. You know, every state is looking to do this, so we're really excited to put something in place, and we're hoping that it can be dynamic and, really helpful for folks in terms of navigating these changes and what it looks like for them specifically, how they go about becoming compliant or exempt and providing that information or even potentially making referrals to do so. So we're working on that. We're hoping to share some more information in the next coming months with you all on what that looks like. Next slide here, the third key area that I'll be talking about is just our overall stakeholder engagement and communication. So hopefully you guys are all aware that we did launch our website on August 29th. For ABA, again, it's at medicaid.utah.gov/ABA. We've included in there FAQs for members, providers. We have a presentation, a timeline. We have a designated email that we put up there, and we encourage anyone to send in questions, suggestions, ideas to that email. We are reviewing that and we'll respond. Colby also put together a really, really great resource right now that gives information on catastrophic health plans that are available right now. I think most or all of you are aware with individuals who will be losing coverage or who have lost coverage through the federal marketplace due to the affordability of those plans. And so, this information is available on our website and I've linked to it here. I can also drop it in the chat after, or if someone else can. But Colby did a great job laying out that, initially, if someone's losing coverage, we do encourage you to apply for Medicaid. Even if you've been closed or denied before, it's possible you qualify. And if not, you can. We do link to the HHS website with more information on these catastrophic health plans. So we'll be putting more information on our website, such as this, that lists up resources and different things, for the public and for people. This next bullet point, we've been doing a lot of work with ACOs, mental health substance use authorities, or will be doing a lot of work. We did initiate a survey that was sent out in October. We have compiled those results and we will be setting up meetings in the next couple of weeks to start meeting and partnering to come up with some strategies on how to, partner together to help lift up resources or helps for individuals navigating these changes. We have also put together a comprehensive communication plan with key dates and tasks, just ensuring that we have a coordinated message to all of our partners and members. We're actively working on this, so more to come. And then lastly here, just wanted to put another plug on how to follow our progress or get involved. Again, through our website here at the MAC, we'll be giving regular updates. And also at the Beneficiary Advisory Council, we actually had a really good discussion yesterday, in fact, with the BAC, and got some really good feedback from them on some concerns and suggestions with these changes. So if you guys know of members or you are a member and you want to join, there's the link to the website on how to join the BAG. I think lastly, just here, key next steps. The biggest thing with implementing these provisions, aside from just being compliant, we are extremely focused on establishing that support system and navigation. So that is one of our biggest key areas that we're focused on, is putting that in place where gaps may exist with these changes. Launching our communication plan and communication toolkit, which will be on our webpage. And then, like I mentioned previously, just we are actively designing, building, and testing our systems and everything that needs to go into place in order for us to be compliant by the due dates. So I'll stop there and just ask if there are any questions for me or anyone else on the call.
Yeah, Rebecca, go ahead.
I just have a question on the update to the website where it points people to catastrophic plans. There are currently no catastrophic plans filed in the state of Utah. Most of the insurance carriers that I've been talking to are hesitant to file catastrophic plans. I've been really pushing it and hoping and encouraging, but we don't currently have any catastrophic plans filed. Do we want to update that, or is there any plan to talk about that at all on this website since it's not actually available in our state?
Yeah. Hey, Rebecca, this is the kind of feedback that we need. So I really do appreciate you raising that. I think we can take that back and talk to Kobe. We were just referencing the HHS website because we don't oversee those catastrophic plans. We were just directing to a resource. So we're happy to take that back and update that information. So thank you for that.
Yeah, I think in the future they're going to be really exciting, but none of the insurance carriers have been willing to jump in and do it yet. So we're hopeful. But today, this open enrollment that ends in 7 days, that is not a choice for anyone in our state.
Rebecca, could I just ask you really quick, is that true of any other states or is that uniquely Utah?
Quite a few states do not have
wow.
plans currently.
I did not know that. Thank you so much for bringing that up. I had no idea. I feel like kind of like a clown now. Thank you.
No, you're fine. I serve on the board at healthcare.gov, and so I'm like deeply involved in all of that shenanigan. And this is one of the things that we're really excited about, but it's not gotten legs yet because the insurance carriers are like, well, that's nifty, but we lost money on those last time, so we don't really want to play.
Okay. No, thank you for making us aware of that, Rebecca. We will, I'll work with Colby so that we can update that. Thank you. And Rachel, I see a question from Stephanie in the chat. I can take that. You know, can you explain the USHE connection? You did not catch that. So basically, Steph, we are, what I was explaining in making those connections to data sources, we are trying to add more data sources that we can connect to verify without having people provide that information. And USHE is one of those connections. It is one of the ways that someone can be compliant is if they are enrolled half-time. So we're actively working with USHE to get that MOU in place and that connection where we can just get that information electronically.
If anyone else has any other questions that are in the chat, or if you're raising your hand, you can just go. I had to switch back to my phone, so I'm not at optimal status, but hearing none, Michelle, I have a question. Do we have access to that SNAP Medicaid gap report? Like, is that public at all?
It's not. That's something I can take back internally. We can discuss. We're still doing some updates to it because there were some recent SNAP changes. So let me take that back and I can get back with you. And
Okay, thank you. Yeah, no huge rush. I just that piqued my interest.
Yeah.
I have a question, Michelle. So I know, like, I was thinking about like how we now have a contract with Truve, the electronic data sharing, whatever that's on my case. I think it's called Truve, right?
Yes.
So whenever there's contracts like that, I'm just curious, I would love to like know, and maybe Rachel, this is actually a question for you, if we can get like a MAC meeting where we like go through some of the like contracts with like data sharing. I know it used to be Equifax and now it's Truve. Like all of these, those things never seem to come in front of the MAC. And I think they really do impact beneficiaries a lot. And also I would love to see some oversight on that process and just kind of hear a little bit about why I don't know if the screening tool that you mentioned, if that's like a screening tool, just like I don't know if it's an app or is it just like a questionnaire? And like, I'm just curious about there's a lot of tech and AI companies that are trying to like profit off of these policy changes. And I would really like to see more scrutiny and oversight on that in the MAC and just for the public to understand those as those business relationships develop.
I think it's a good comment, Stephanie. I think quickly on Truve, and if Melissa wants to add something, please feel free. But an important aspect to TRUV is it's all consent based. So a member is not obligated to consent to TRUV. It does, we're seeing a lot of states that are interested in providing this option because it gives a better and cheaper tool for verifying both hours and income that can be helpful for compliance for HR1 and more speedily allow for determinations. But if Melissa would like to add anything to that.
Yeah, so Stephanie, we actually still use Equifax as well. We have a variety of different methods that we do electronically verify. TRUV is one that's a little bit cheaper, and as Brian mentioned, it's consent based. So we kind of have a tier of how we go about doing that. As far as verifying, the things that we look at from the state perspective is cost. We've recently moved different things to save on costs and things like that. So we have a variety of methods, but TRUV is one that this is kind of outside of HR1. This is something we implemented a couple years ago, but yeah, we have a variety of things that we look at statewide. We're always looking at things to kind of further use technology so that customers don't have to be as involved in gathering verification. So that's something that we at DWS and with DHHS are constantly looking at to see how we can streamline processes using technology and vendors.
Thanks, Melissa and Brian. I guess, Rachel, I think it needs to be an agenda item, because I think you bring up a great point, Melissa, that you guys see it as a way to have members, customers, whatever you want to say, have less time. That is not what I hear at all. I think it's causing a lot more time, because I just think it's worth having a conversation, because if there are a lot of methods you all use, I don't think that that's ever been discussed on the MAC, and I think it would be a good conversation, because while TRUV does have a consent, you know, I just helped somebody with it, and so I know it's not as clear maybe to like these things need to be done with with the people that are actually navigating the system, because they can consent would mean that they actually understand like what they are consenting to, and I don't think that that is the case. And I do think that like there is a risk that when you use data sharing sources, like when you're doing data sharing and data linkages and data connection, and the people who are like the most impacted are unaware of that, they become mistrusting of the whole system, right? Because it just feels like this is just what I hear a lot. And so I do think it's worth having a conversation about, because it would be interesting to know if when there are these contracts and these, you know, advancements in technology, are they actually reducing beneficiary time tax? Because that doesn't seem to be the case. And we were really high on procedural disenrollment, so it doesn't seem like it actually made a positive impact. And so I think it would be interesting to have a conversation in a public setting. So Rachel, I don't know if that's something that if somebody else wants to suggest that.
I have a comment also. Oh, sorry.
Yeah, go ahead. Sorry.
Oh, it's okay. Sorry, I wasn't sure when I should go. But I think that it does actually save time, because I've been to my case. And so if I'm trying to do my case review every year, it already knows what my SSI amount is. And it knows that like it can go link to my bank and know what my balance is, which I'm required to submit for that review. And it does actually tell me where it got the data. It's like, well, we got this data from these sources. It tells you that before you go to the next page.
Thank you. Yeah, I would like to, I think that this is, personally, I think that this would be a good agenda item to have going forward. I think that there's probably some benefits here, but some drawbacks too. And I would like to see this as a larger agenda item. So Steph, I can bring this up in executive committee for a future meeting. I think it's a good part of a larger discussion around implementing HR1 and just eligibility in general. I see personally the HR1 as maybe an opportunity, maybe that's too positive a word, but an opportunity to go in and look at what we're doing now and what's working, what's not, and then looking at other states too. So I would like to see it as an agenda item, and Sharon, I will remember this one, but if you could add it to our running list, if you don't mind. And then Michelle, I know that you wanted to go.
Are you talking to me, Michelle? Sorry.
Yeah, I think
Oh.
was it you? Sorry.
No,
My screen is so
sorry.
small.
I didn't have anything. I'm sorry.
Oh,
I'm sorry.
sorry.
If it sounds like
I thought
did.
someone else said had something else. Was there someone else that I cut off? Okay, apparently not. Anyway.
Well, maybe I'll just add, Stephanie, you also had a question about the screening tool, and we do plan to give more details on that in this body. So once we get more details about the screening tool, we will bring that here.
Thank you, Brian. Is assuming that's the end, Michelle,
Yeah,
Okay.
I think I
Good.
would just say, Rachel, thank you guys for allowing me to bring this here and talk about it. And I do welcome, again, just another plug. I do welcome feedback, suggestion, thoughts, questions. So please send those to me. You can either send those to me directly or through that designated email that's on our webpage. Thank you.
Awesome. Thank you, Michelle. And thank you, Brian and Melissa as well for adding information. I think that's the end. Sorry, I really am on a very small screen right now. Yeah, and last agenda item will be number 8, committee member updates. So I will shut up for a second, and then if any committee members have any updates, requests, comments, now is your time. All right, hearing and seeing none, I think that brings us to the end of our agenda. As a reminder to folks, our next MAC meeting will be on February 26th from 10 to noon, and this will be a hybrid meeting, I believe. Yes, it is hybrid. It will be at the Capitol as well as online in the North Capitol Stateroom, which is in the new building. I know we're all very excited to see it. I personally am excited to have more parking. But we will see you then virtually. And remember, this is an informal meeting. This is really just to discuss requests for appropriation and bills related to Medicaid and Medicaid beneficiaries during the legislative session. So this won't be a normal MAC meeting. We'd love to have you anyway. It's personally one of my favorite MAC meetings, believe it or not. But with that, I believe we are done with our agenda, and we will see you in February. And just as a heads up, Matt from UHPP has dropped a link to their annual conference, which will be this time next week. So if you all are interested, Matt has a link in the chat, but you can also Google UHPP annual conference and it will come up. But with that brings us to the end of our agenda. Have a wonderful rest of your days, and have a good upcoming weekend.
Thank you.
Bye.